So, with maximal TURs, obviously you can have bladder perforations. And, I think it's one of the things that we all fear and try to avoid so much as is within our control. Of course, we could talk about this at length, but general kind of thoughts on how bladder perforation impacts your management. Let's just, broadly put it in non-muscle invasive and muscle invasive scenarios.
And tough one, and not something we like to see at all. And of course, we take every precaution we can to try to avoid that. If it does happen, and it happens more often than I think we talk about, at least microperforations, where there's some seepage. Surprisingly and shockingly, I don't think we get a lot of seeding outside the bladder, provided you don't continue using, high pressure irrigation to a reasonable degree, stop the procedure as soon as you can if you see a perforation. I tend to be fairly conservative in management. It doesn't happen often, but the only time I think is indicated to actually go in and either repair the cystotomy, which I've never done, or just place a drain or irrigate the fluid is a large perforation. Patient's clinically not doing well, and you've got large volumes of fluid in the abdomen, which again should not be common. You should always be aware of how much fluid is going in and out roughly, and make sure that you don't get a delta of 5 liters that is ending up in the abdomen. I always teach the residents, always have one hand on the abdomen, back and forth, to make sure the abdomen is soft, continues to be soft, and we're not getting distended. Now we say that, and you have a patient who's 280 pounds on the table, and their abdomen is quite rotund, and it's difficult. So it's not always easy to palpate, a fluid collection. You can probably dump 2 liters in the pelvis and not know it in a morbidly obese patient. So again, sort of vigilance about how much fluid is going in and out, roughly making sure you're keeping an eye on the suction device and how much is coming out.
And then in terms of oncologic management, say, the path comes back muscle invasive and they had a perforation. Does that broadly affect the way that you're going to manage them?
Yeah, I think it certainly pushes me to do neoadjuvant chemotherapy in that setting, and then followed by cystectomy. What I have seen with very large tumors, and I have one unfortunate case that I'm managing right now, is the unrecognized ones where a tumor does end up on the outside of the bladder, and eventually, maybe 6 months or a year later, will grow sort of from the outside back into the bladder, or just you have an extravesical growth. This was the current case I have is with a non-muscle invasive patient who really had nothing going on in the bladder. Meanwhile, this tumor was growing on the outside from a TUR from 2 years prior, and had vigilant follow up. Yeah, certainly again, systemic therapy followed by cystectomy to make sure we remove all the surrounding tissue that may have been affected.